Good morning, everyone.
Good morning.
Pediatric going around. Thank you for joining us online and in person. If you are anywhere close by, please join us in the mountain conference room at the Carilion complex. Feel free to send in any questions online. Today is Dr. Nicholas Ryder. He's a board-certified clinical immunologist and clinical informaticist. He has a long-standing expertise in the clinical management of patients with complex immunological disease and in clinical data science approaches for optimizing patient care. Dr. Ryder serves as a professor in the Department of Health Systems and Institution Science at the Virginia Tech Carilion School of Medicine. Additionally, he's an Associate Chief Medical Information Officer focused on research data operations and a clinical immunologist at the Carilion Clinic. I believe he sees patients here once a week, right upstairs on the Tanglewood complex, so please send all the referrals to him. Please join me in welcoming Dr. Nicholas Ryder.
Thank you so much, Dr. Parmeshwar. Really a privilege to be here chatting with you all again. And can you hear me okay in the back? Coming through okay? Yeah, I know this room is really fantastic from an acoustic standpoint. So yeah, as stated, I've been here at Carilion for about 18 months, came from Texas Children's Hospital down in Houston, and I really wanted to make a career out of taking care of the patients that I'll chat with you about today. Did a grand rounds back in February, and that was focused a lot on kind of the research that I do and how that can improve health system operations for patients with primary immune disorders, sometimes called inborn areas of immunity, or I like PI, it's just simpler, right? So my focus has been very much around finding these patients, getting them the care that they deserve and need, and with the understanding that they're a complex group from a scientific standpoint, also a clinical presentation standpoint. They really do require multidisciplinary care. Very grateful to be here at Carilion. At TCH, it was wonderful, but there were 8 of us doing this kind of work, which was fantastic. But not everyone lives in Houston, right? Not everyone lives in Boston, not everyone lives in Philly with these disorders, or San Francisco, or you name the major metropolitan area where there's a huge health system. Carilion is a huge health system. We care for a large landmass of patients. And what's been really heartening, and I want to give a shout out and thanks to my colleagues here in the room, is that we're starting to forge partnerships to keep these patients who live around Roanoke with primary immune disorders close to home, with multidisciplinary care here at Carilion or with other centers in the region. So the title of this talk is really When to Suspect Primary Immune Disorders, and I really want this to be heavily clinically based and relevant. So just some of my disclosures, none of which are really relevant to the talk today. What I'll talk about is what is primary immune deficiency or primary immune disorders, and talk a little bit about the epidemiology. Again, I want to give you a case-based tour, thinking about how do these patients present, what kind of clinical problems do they suffer from, and what kind of teams are really required to care for them optimally. I want to talk a bit about genetic testing for these diseases. I'm so happy that I think Dr. Doherty is in the room. Yay! So we have our geneticist here, fantastic. And we practice down the same corridor in this building at Tanglewood. So we have a wonderful relationship as well. Talk a little bit about the workup, the initial workup and evaluation of these patients, and hopefully some key takeaways. So who knows who these people are? Anyone know? Any thoughts?
That's the boy in the bubble.
The boy in the bubble. Excellent, excellent, excellent. That is David Vedder on the right, the boy in the bubble, cared for at Texas Children's Hospital. He suffered from a condition called X-linked SCID, which arises from mutations in the IL-2 receptor gamma chain, major cytokine signaling receptor, which if deficient in that, you knock out all T, B, and typically NK cells, but definitely T cells and B cells. And the gentleman on the left is the late William T. Shearer, who came from WashU to Texas Children's to care for David back in the 70s and 80s. So both of these individuals, as well as many others, have participated in advancing the science and clinical knowledge around primary immune disorders. Sadly, David lost his life after a failed bone marrow transplant in the early days of hematopoietic stem cell transplantation. But this was a picture taken, in the early 80s. when we knew about, really a single defect, X-linked skid at the genetic level, now we know of over 500 genetically defined inborn areas of immunity or primary immune disorders, with 550 distinct diseases described now that span every arm of the immune system: T cell defects, B cell defects, combined defects. Every arm of the immune system we now know of defects that cause human immune problems. And what we once thought of as primary immune deficiency, recurrent infections, severe and unusual infections, we now know that is part of the spectrum. I'll talk about that. But pathological inflammation, immune dysregulation, autoimmunity are also part of this spectrum. So there's a lot of overlap within clinical immunology, rheumatology, hematology, oncology, infectious disease. And so clinical immunologists as a community do encompass allergist, immunologist, infectious disease, hem-onc, rheumatology. And this is just showing an infographic on the left of really the expansion and the understanding of this landscape, starting from the mid-'80s, where we knew about one disorder, and then as of the report, this Journal of Human Immunity report from just earlier this year, we're in the mid-500 range in terms of describing disorders. The busy table bar chart on the right is showing you the distinct, and I'll talk a little bit about this, types of immune disorders across the tables in a document that's put out by the International Union of Immunological Societies, where, see, table 1, and we're actually going to go through cases from each of these tables to make it much more relevant and I think hopefully more interesting. But what you can see is in blue, the number of disorders, genetically defined disorders, as of 2022, and then in red, the disorders that have been described really over the past 2 to 4 years. So you can see that this is progressing quite rapidly, and the largest growth is within the table 4 set of disorders, which is immune dysregulation. These are a group of patients that present not only with recurrent and unusual infections, but also inability to recognize self from non-self, so some autoimmunity, but also lymphoproliferative disease, large lymph nodes, bulky lymphadenopathy, hepatosplenomegaly, and inability to really regulate immunity. So, how do these patients present? It would be easy if they all showed up with a really unusual infection and we said, aha, I know you've got a problem with your immune system. I'm going to talk with Dr. Doherty, and we're going to do genetic testing, and we're going to find out the answer, and we're going to get you on to appropriate therapy. But sadly, there's this very mixed picture, and this was a nice ESID, European Society of Immunodeficiency, registry-based study of over 20,000 individuals from 29 countries that I think really nicely shows that these patients present with, yes, lots of infections, but sometimes common infections that just happen more regularly, sometimes very severe infections, sometimes very unusual and frequent and severe infections. You see immune dysregulation, some syndromic features, we'll talk about that, as well as a variety of other problems, including just laboratory defects that may or may not be clinically significant at the time of finding. This busy slide really underscores the fact that these patients present a wide variety of ways that is just not always easily ascertained. So, this is just a figure showing that last slide's description, kind of a proportion chart showing that the vast majority of these individuals do present with infections alone. So about 2/3 of patients with PI present with severe, unusual, recurrent, or frequent infections alone. But as this infographic is also showing, many present with immune dysregulation, infection and dysregulation, and so forth and so on. And so depending on what type of primary immune disorder or what category or class of immune disorder you're focusing on, antibody deficiencies are typically infections alone, for example, whereas combined immune defects may have other symptoms, and then in disorders of immune dysregulation, as described earlier, have dysregulation without infection. So, again, a very heterogeneous clinical picture. And, these patients, if they're younger, they tend to have infections, but over the lifespan, you see more infections over time, whereas immune dysregulation presentation is variable, and you can't necessarily say, a young patient is going to present with dysregulation or not. So we're still learning a lot about this category of disorders. What we do know, what I've focused on in my research lab, which is a dry lab, a computational lab, is bringing these patients to medical attention sooner, because we know the diagnostic lag is very real for these patients as well as other individuals with rare diseases. And so whether you look at antibody deficiency such as common variable immune deficiency or the immune dysregulatory disorders or primary antibody deficiencies, these patients from initial symptom onset to time to diagnosis span anywhere from 5 to 8 to 9 to 10 to 20 years. And this leads to everything we don't want in healthcare. Suffering, long diagnostic odysseys, really suboptimal outcomes due to recurrent infections that impair organ function, missed opportunities for best care referrals, and so forth and so on. So this diagnostic lag, to no one's surprise, although it hadn't been quantified until recently, is a tremendous burden on the patient, certainly the health system as well, but most importantly the patient and the family. And so if we consider this, time from birth to maybe asymptomatic period, this kind of silent period, and then a symptom will emerge that's indicative upon reflection of a primary immune disorder, and then this diagnosis, and then ultimately outcomes that really stem from the time from first symptom onset to diagnosis. We consider this to be the diagnostic lag. So the time from first attributable symptom to the underlying disorder to a formal diagnosis to be the diagnostic lag. And a really talented medical student, Serena Nixon, dove into a large registry put out by the Immune Deficiency Foundation. And she studied about a little over 1,100 primary immune disorder patients. Most of these individuals had antibody deficiency. And just to kind of boil this study down, this was an observational study where she looked at one single question that related to patient-reported health, and that was for patients with antibody deficiency. How would you rate your health? And she looked at various factors that skewed towards individuals saying, I would rate my health very poorly. And she found that diagnosis age of less than 12 years of age was favorable, so greater than 12 years of age, unfavorable. A shorter diagnostic lag, less than 10 years, still a long time, right? 10 years from symptom onset to diagnosis, a long time. But if it was shorter than 10 years, that was favorable. And if these patients saw less than four clinicians at the time of diagnosis, that was also favorable. What had no effect on patient-reported health was the specialty of the individual making the diagnosis. So it didn't matter whether you were a clinical immunologist, a general pediatrician, a family doctor, making the diagnosis of these patients is the ultimate aim. And in other specialties such as hematology oncology, we know that patient-reported health is linked to mortality. So we also suspect that for these diseases, but we don't have data to support that, but we strongly suspect it. So how common are these disorders? Are they rare? They're considered individually rare diseases. So if we talk about, say, X-linked severe combined immune deficiency, as mentioned with David Vedder, the bubble boy, yeah, that might be an incidence, of somewhere around 1 in 100,000 individuals. But collectively, PI is not rare. And so we did a large US-based de-identified EHR study through Optum and found that the prevalence of primary immune disorders is estimated about 60 per 100,000 individuals. And this was US-based, looking at about 73 million individuals across the US, so roughly a quarter of the US population. It's the largest sample study within primary immune disorders to try and ascertain the prevalence, and it actually falls within smaller cohort studies that have been done throughout the world, ranging from 10 to about 100 individuals per 100,000. So this data here also on the left is from our publication, which shows that, has anyone heard of the 10 warning signs of Jeffrey Waddell Foundation? I see some folks nodding, raising their hands. Yes, so the 10 warning signs put out by the JMF are really a heuristic or a rule of thumb for considering the diagnosis of primary immune disease in a patient presenting either with recurrent ear infections or sinus infections or excessive use of antibiotics and so forth and so on. So in this registry study, in this US-based EHR study, we looked at the individual warning signs put out by the JMF and then encoded them amongst our 41,000 individuals with primary immune disorders, and then asked the question, which warning signs were most informative, understanding that not all would be weighted equally. We found that this warning sign 9, which is 2 or more deep-seated infections, including sepsis, which we also encoded as immune dysregulation and opportunistic infections, was weighted almost 8-fold amongst those individuals with primary immune disorders. So again, a variety of clinical findings, a variety of different weightings for the 10 warning signs across these 41,000 individuals. So what does that really mean for a U.S. population of now north of 331 million? Roughly, we would have about 200,000 individuals with PI in this country. And these are individuals that likely have a fairly penetrant phenotype, a fairly severe phenotype that's clinically recognizable. So you think about the other individuals who haven't yet presented with significant symptoms across that spectrum I showed earlier, and we're probably upwards of 400 to 500,000 individuals across the U.S. with these diseases. So again, individually rare amongst those 550 distinct disorders, but collectively not so terribly rare. So we've stood up an ECHO program. Who's heard of Project ECHO here? Yep, see some nodding heads. Yeah, so a program out of the University of New Mexico started by a gastroenterologist originally focused on hepatitis C, which is now spanning the globe. We are one of over 1,000 programs based here in Roanoke called PEPI, Project ECHO for Primary Immune Disorders, and we're focused on really advancing support for rural clinicians who may be caring for patients with PI or considering the diagnosis. So we have a website, you can hit that QR code, get to our iEcho site, we have a YouTube site where we have enduring materials put out. We also have a CME series, which I'm very grateful to Carilion Clinic for sponsoring and supporting that, and we hosted our first CME session just last month. We'll have about 10 more sessions throughout the next year. And you can see that thankfully this is not just me in PEPI, 2 colleagues from the University of Virginia, Dr. Monica Lawrence and Dr. Larry Borish, as well as a really talented nurse in Lynchburg, Angie Tyree, and one of my graduate students, Jacob Blankovich. So we're trying to get at improving diagnosis, management, and care for these patients locally so that, again, they can stay closer to home and have optimal outcomes. PEPI is focused, again, on rural case consultation, providing analytics consultation, hopefully embedding some of the AI machine learning pipelines that we've built into rural health systems, including areas of the Carilion Clinic system, in addition to providing education and QI approaches. We kicked off in just a little over a year ago. We've had a number of educational sessions, as mentioned, in the CME session. So, okay, let's do this case-based tour. I can see it in your eyes. You've been caffeinated, and now you want to talk about patients. Awesome. So we're going to go through 8 of the 10 tables in the IUIS document. So keep sipping on that caffeine and that coffee. But we're going to start with combined immune deficiencies. So as a group, this represents maybe about 15% of the population of patients of diseases within the PI spectrum. This is where severe combined immune deficiency falls. Thankfully, the vast majority of combined immune deficiencies, which affect both T and B cells, are now picked up through state-mandated newborn screening, which every state in the nation does now, as of about 2018. This is the T cell receptor excision circle-based assay, or the TREC assay, that looks for the generation of new T cells through just measuring these little episomes of DNA. And you can ascertain in a newborn within the first week of life whether their thymus is functioning normally. And so thankfully, many of these individuals that used to present very severely ill are now detected pre-symptomatically in the newborn period. So this is a case, and these are all cases from my practice. Some of the pictures are from the actual patient, some are not. But this is a patient with severe eczema and infections. He was 8 years old at presentation when I met him. He had severe atopic dermatitis, recurrent bacterial pneumonias, and a sensitive staph sepsis episode. He also had food allergy. So you can see in the picture on the left this eczema on his face, and what you might not be able to see on the picture on the right is this clouding of his left cornea. He had an episode of HSV, keratitis, so this is an unusual infection. I think we'd always all agree. But his clinical picture, food allergy, eczema, not terribly rare, but these bacterial pneumonias and sepsis certainly raised the specter of an underlying immune disorder. So again, just underscoring what he presented with clinically, some of his labs, he had hypereosinophilia, he had a strikingly high IgE level that was above the limit of detection, and his CD4 and CD8 counts were relatively low. He ultimately underwent genetic testing, was found to have an autosomal recessive form of hyper-IgE syndrome called DOCK8 deficiency. DOCK8 deficiency is a severe form of hyper-IgE syndrome. These individuals, again, have severe atopic dermatitis, T-cell defects, and the hyper-IgE syndrome. So the treatment for these individuals is initially supportive, giving them suppressive antibiotics such as Bactrim, antifungals, but ultimately they need hematopoietic stem cell transplantation or bone marrow transplant. For this individual, he was placed on prophylactic acyclovir, Bactrim, and at the time of my last contact with them, the family was considering stem cell transplant, but he had not undergone transplant. This is some photos from the original description in the New England Journal of DOCK8 deficiency. What you see is the kind of severe atopic dermatitis in panel A, some of the mucosal lesions in panel B, terrible warts in C, and then molluscum in panel D. These individuals die early if not detected, but maybe not in infancy. From this Journal of Allergy and Clinical Immunology figure from 2015, you can see those that were alive and deceased at certain ages, and well over 50% had passed away before the age of 10. This is a very severe disease, needs to be diagnosed early, and these individuals need to be referred to a transplant center to really have meaningful survival moving forward. So the next category is combined immune deficiency with syndromic features. Combined immune deficiency, the previous table, again, we see a lot of those individuals picked up. They look clinically normal like any other baby, but they have an abnormal newborn screen that suggests a T-cell defect. Many of these CID, combined immune deficiency individuals with syndromic features, can actually be recognized through their physical features, whether they have a skeletal dysplasia or a condition such as DeGeorge syndrome. Sometimes the facial features and other just clinical findings might tip you off that they have an underlying complex immune disorder. So this is a patient who presented at 2 months of age, was born at home to an Amish family at 35 weeks of gestation, was noted to have short limbs at birth and presented in respiratory distress. So was born at home well, but over the first 2 months of life became quite ill. On exam, there was evidence of short-limb dwarfism. There was evidence of inspiratory crackles and respiratory disease. This is not a picture of, this is a very happy child with this disorder, but this is a picture of an individual with this disease. And you can maybe see the increased carrying angle and the shorter limbs in the picture, which you can definitely see if you got plain films of especially the lower extremities, are these abnormal diaphyses, which are very characteristic of this particular disease. This individual had low T cells and absolute lymphocyte counts. It was lymphopenic, low B cells. Also had abnormal lymphocyte proliferation to mitogens, and had a nasal wash that was significant for parainfluenza type 3. The IgM and IgA in this individual were undetectable. IgG was normal. Why? Maternally inherited transplacental transfer, but also had CMV copies detected. So this is an individual with skeletal dysplasia, so syndromic features and also evidence of a combined immune deficiency. Would this individual have been picked up if they underwent state-mandated newborn screening? Probably, but because the child was born at home, newborn screening was not sent, so we missed that opportunity. Genetic testing was done and found to have homozygous mutations in RMRP, a gene that's known to cause, when mutated, a condition called cartilage hair hypoplasia. So this is a short-limb skeletal dysplasia, which has variable immunodeficiency. Some of these individuals have no immune deficiency whatsoever, or immune disorder whatsoever. Others have really a transplantable combined immune deficiency, and that was indeed what this child had. So he was stabilized with intravenous immune globulin, given ganciclovir to treat his CMV, and also placed on Bactrim, ultimately a matched unrelated donor transplant with some immuno-occlusive disease complication, but ultimately engrafted and did well. So this was a success story, despite presenting, quite ill and a little bit late, with this combined immune deficiency. Cartilage hair hypoplasia, or CHH, is a classic primary immune disorder where you've got a combined immune deficiency, in this case skeletal dysplasia, so it is a syndromic combined immune deficiency, but you see a wide variety of other multi-system complications, from autoimmune disease the aganglionic megacolon or Hirschsprung's disease, and so forth and so on. So these patients are, again, really needing multidisciplinary care once their diagnosis is made. So if I said, who here in the room has cared for a patient with PI? Anyone? I see some hands going up. How many of those individuals who care with a patient with PI have cared for a patient with an antibody deficiency? So low IgG, low IgA, low IgM. Yeah, I see some hands going up, absolutely. So this is the proportion of individuals within the domain of PI that is the greatest. About 50% to two-thirds of the individuals in any population with PI have antibody deficiency. So this is the X-linked agammaglobulinemia, the common variable immunodeficiency. These are the individuals who need antibody replacement with IVIG or subcutaneous IgG, really for lifelong to keep them free of infections. These individuals often present with recurrent sinopulmonary infections and sometimes abnormal, really unusual and invasive viral infections. So this is the case of a serious bacterial infection in individuals who suffer with SBIs as well as joint disease. He presented at 4 years of age with numerous episodes of septic arthritis. He had joint deformities by the time he came to us and had a history of recurrent bacterial pneumonia and just chronic draining ears. Just basic immunologic evaluation, he had a mildly depressed absolute lymphocyte count of 1,200 cells per microliter, but he had very markedly low immunoglobulins across the spectrum. So IgG, AM were all virtually undetectable. And we progressed on, and I'll talk about this a little bit later, to do some flow cytometry to assess his T and B cell compartments. He made almost no B cells whatsoever. This is a picture of his right knee. So this is the knee projecting out of the plane of the screen. So his foot would be in the inferior portion of the lower portion of the screen, and his hip kind of back into the plane of the screen. So you see this bulbous, abnormally shaped, right knee with this, this vertical scar from numerous aspirations and clean joints, open OR needed to clean out and debride his joint infections after multiple episodes of septic arthritis. He also underwent genetic testing based on the fact that he was a male making no antibody with a chronic serious bacterial infection history. This was single gene Sanger sequencing, so a BTK or Bruton's tyrosine kinase sequencing was done, and he was found to have a variant there that was associated with the X-linked form of agamaglobulinemia, otherwise called XLA. He was placed on IgG replacement therapy with IVIG monthly and did quite well. Kind of spoiler alert is his diagnosis was known clinically before he came to us, but he had a lot of problems in receiving frequent, regular immunoglobulin replacement therapy, which led to his numerous episodes of septic arthritis, pneumonias, and so forth. Another great example of multidisciplinary care needed, and that in addition to immunology and good pediatrics care, he absolutely needed orthopedics to help with the joint deformities, and that despite having a chronic flexure of his knee, he was one of the busiest kids in the exam room, climbing all over, had a bright smile, lit up the room. So, it wasn't holding him back sufficiently, but he definitely needed help and was ambulating a lot better after a couple of years in the care of orthopedics. So XLA patients, again, suffer from a wide variety of different pathogens, as shown in the table on the right. You make the diagnosis mostly clinically, but now, of course, with genetic means and or flow cytometry, noting that you've got less than 2% circulating B cells. So moving on from antibody deficiency to diseases of immune dysregulation, a little bit more of a rare set of diseases that can present in unusual fashion and not typical, not with a kind of canonical clinical presentation. This is a patient with an atypical ADEM, not that ADEM is ever typical, but he had acute disseminated encephalomyelitis early in life. He presented at 5 years of age after having this diagnosis made at about 3.5 years of age. He developed hydrocephalus. He also, in kind of the ensuing years, had recurrent bacterial pneumonias and had been hospitalized intermittently. And upon kind of reviewing his history in the electronic health record, it was noted that he had chronic lymphopenia and protracted, really, anemia. His history was really striking in that he was like any other child until about 3.5 years of age when he developed these ear infections and pneumonias. And he had been given all vaccines without incident. Sometimes you'll see that the individuals with Semi-subclinical T-cell defects can have abnormal reactions to live viral vaccines. So they can have, Oka strain breakthrough with varicella vaccination. Sometimes the rotaviral vaccine will make them symptomatic. And this child, again, he has a different disorder of immune dysregulation. He handled all live viral vaccines and other vaccines without incident. So his ADEM, just talking a little bit more about that, he presented with aphasia, ataxia, and dysphagia. So very scary and horrible to see this. He ultimately developed bacterial meningitis after he had this EVD placed. So a lot of complications in the CNS, and clearly this was a manifestation upon, I'll tell you his diagnosis in a moment, of CNS-related immune disorder. At the time of evaluating him when he was 5, he had a splenomegaly, and his relevant labs suggested this chronic history of lymphopenia with a very low absolute lymphocyte count spanning the 200 to 700 microliter range. He had this mild anemia that had been chronic, an elevated ferritin triglyceride level, and soluble IL-2 receptor. So anybody that I tell you has an abnormal soluble IL-2 receptor level, an abnormal ferritin triglyceride, anyone thinking of any particular disease?
HLH.
Yeah, right on. HLH, hemophagocytic lymphohistiocytosis, which is why we like to call it HLH. This is a picture of HLH, but it was very much smoldering. So he had these stepwise, very unusual clinical events that didn't really manifest until he was quite ill. He was quite ill at this time at 5 years of age, so he underwent genetic evaluation. He had a trio, meaning both parents and him, being the proban, underwent whole exome sequencing, was found to have inherited allele that's segregated by the parents' variants in the UNC13D gene, which is, I'll talk a little bit more about that. So this clinched the diagnosis of familial or primary HLH, as opposed to secondary HLH, which you can get as a result of viral infections such as herpes infections. So he was hospitalized with this pneumonia and cytopenia at that time. Sadly, he had progressive disease and did not respond to etoposide. Etoposide steroids didn't quell his inflammation, and he died 18 months after his initial presentation. So this is, again, a terrible outcome due to a terrible disease. Certainly, there are a lot of individuals working around the country and the world to find this diagnosis earlier. We're still using criteria from an HLH 2004 trial that includes both molecular diagnosis or 5 of 8 clinical criteria, such as fever, hepatosplenomegaly, the elevated ferritin triglyceride, and soluble IL-2. Again, many of these patients present quite sick and succumb to the disease because of it. HLH is a disease of kind of frustrated cytotoxic killing, and that you have a target cell that you're trying to destroy if you're an effector cell, either a cytotoxic T lymphocyte, a CD8 cell, or an NK cell. And these cells, as you know, they find these target cells, they punch a hole in the membrane with perforin, and then they release cytolytic granules into the cytoplasm of the target cell to lyse it, destroy it, and cause apoptosis. In the cases of HLH, and there's a number of genes along this pathway, including the UNC variant, UNC gene that I mentioned, you have these defects anywhere along the pathway where the effector cell can't kill the target cell, so you have pathological inflammation that is just amplified exponentially, which causes hepatosplenomegaly, lymphadenopathy, recurrent fevers, and an inability to kill. So this is truly a disorder of pathological inflammation, severe, overwhelming, multi-system inflammation. So we're getting there. We're on to phagocyte disorders. So these are the neutrophil defects. These are the defects that cause abnormal dental infections. Many of your patients with neutrophil defects will need to have multiple teeth pulled, chronic severe gingivitis, sepsis due to gram-negative bacterial microorganisms, and a wide variety of other serious bacterial infections, in particular abscesses, deep-seated organ abscesses. So this is a case of pneumonia in a toddler that exemplifies the phagocyte disorders. This was a 15-month-old female who presented to the ER with increased work of breathing. So she had been healthy child up to this point, and just presented with signs of pneumonia. She had one ear infection and a urinary tract infection. Urinary tract infection probably in no way, shape, or form contributory or related to her underlying diagnosis. She was well cared for in good primary care, tolerated all of her live vaccines, and had this kind of potentially relevant family history, and that she had a maternal uncle who had had meningitis twice. So it's maybe related, maybe not. No other diseases known in the childhood, no chronic illnesses through the family, and she was the first child. So at this time, you can see this is an x-ray from her, from the patient. We have these bilateral hilar densities that you're seeing here. I am not a radiologist, but I always appreciate the red arrows, like many people who are not radiologists. A CT was done, and you're seeing this really multifocal complicated pneumonia bilaterally on the CT. So she had very severe, complex pneumonia, and ultimately declined from a respiratory standpoint, was admitted to the pediatric ICU. It required mechanical ventilation for this, for progressive respiratory distress. And because of this kind of protracted and severe presentation, she underwent bronchoscopy with BAL. The BAL revealed Burkholderia cepacia. So when you hear B cepacia, what are you thinking? CF, right? And right after CF, what are you thinking? Yeah, I'm hearing some. I can't quite make it out, but to a person with a hammer, everything's a nail, right? So I'm an immunologist. So CGD, chronic granulomatous disease, excellent. Hear that from a few people. Spot on. So this led to a confirmatory diagnostic test. You're probably going to say, he's going to send genetics again. Yes, but not yet. So what we did is we did a test called a dihydrorodamine flow cytometry test, or a DHR test, and this measures the capacity of neutrophils to undergo oxidative burst and oxidize by a fluorochrome called dihydrorodamine. And what you see here is actually the histograms from the patient and a control. So the spoiler, kind of the gotcha on this test, is you need to send a shipping control if you're sending this test to Mayo or ARUP, unless you have a lab in-house. Because if the cells die, they're not going to be able to undergo oxidative burst, and that doesn't necessarily mean you have disease. So, but what you see here is the control and the patient cells at rest, and they look very similar. Once you activate the cell, then the cell should undergo oxidative burst. And in the control patient, you see this entire cell population shifting its fluorescence intensity over to the right. So the entire histogram population of the cells do what they're supposed to do after stimulated. In the patient, however, you see this huge population of cells that don't shift, and then this smaller population that does undergo some oxidative burst. And so even if you didn't have a great geneticist like Dr. Doherty that said, this child needs genetic testing, let's clinch the diagnosis, you can look at this histogram and largely say this patient with a clinical history and this pattern probably has autosomal recessive chronic granulomatous disease. They don't undergo oxidative burst, but they have this small population of cells that kind of do, as compared to the X-linked form of CGD, where you would see just this single spike. You would see nothing shift over. So ultimately, this individual did undergo genetic testing. He was found to have NCF variants in a gene called NCF that encoded for one of the members of the cytochrome P450 cytochrome oxidase, NADPH oxidase system, suggestive of autosomal recessive CGD. She was given kind of the trio of therapy that's needed for these patients, hopefully prior to transplant, that is Bactrim, to prevent them from getting infections such as nocardia and staph, which are big killers in these patients, as well as itraconazole, the number one killer being aspergillus non-nidulans, and interferon gamma. She did undergo a transplant at 27 months of age and did quite well. So moving on to innate disorders, again, a relatively rare set of disorders. This is a patient from my practice who presented really pretty well. She had short stature and chronic persistent vaginal discharge. She was 7 years old when she originally presented with this. She also had recurrent thrush. She'd never been hospitalized, never been severely ill, and she was kind of lost to follow-up for about 3 years and re-presented at the age of 10. When I saw her, met her initially at the age of 10, she continued to suffer with this, what we now know was chronic candidal vaginal infections, and she had had a recent pelvic exam. This had been cultured many times and been found to be Candida albicans, but in this case, there was no culture obtained. She had classic external signs of vaginal candidiasis. She was given fluconazole with resolution of symptoms, and while she was on fluconazole, she did well. She didn't have thrush, she didn't have candidovaginal infections, largely did well. Her exam of relevance, she was at the 5th percentile for height, but she didn't appear to be failing to thrive. Her weight was normal. She didn't have any syndromic features to be concerned about. She was very bright at the time of exam, did not have thrush, but she did have this kind of mild rash on her face. Her lab showed lymphopenia. She had a low T cell count, but otherwise largely normal immune evaluation. Because we did suspect that she might have a prior immune disorder, we did genetic testing, so you're hearing a theme in all these cases. And she was found to have a variant in the STAT1 gene, so an important member of the JAK-STAT pathway, very important, pervasive cytokine or cell signaling pathway. And this particular variant was known to cause a gain in STAT function. So she was diagnosed with STAT1 gain of function, placed on fluconazole and Bactrim, and followed carefully. So, STAT1, what she had is a condition called chronic mucocutaneous candidiasis, which we've probably all heard of. And she had a relatively mild phenotype. And so what's known about STAT1 gain of function is that some of these individuals just have CMC, or chronic mucocutaneous candidiasis. Others have severe problems like severe bacterial infections, severe viral infections, and even invasive fungal and mycobacterial disease and autoimmune disease. Poor outcome predictors in this group of patients are those who develop aneurysms for some reason. Vascular disease is prominent, especially in older age amongst these individuals, malignancy or really severe infections. So just looking at some of the literature, what the top panel and panel A is showing that the proportion of individuals without chronic mucocutaneous candidiasis who have STAT1 gain of function really drops virtually to 0 by about 20 years of age. So almost everyone, by the time they become late teens or early 20s, develop CMC if they have STAT1 gain of function. But that panel B shows these two populations. The blue line are those individuals with STAT1 gain that only have CMC. The red line shows you this Kaplan-Meier curve, the survival curve of these individuals with the more severe infections, the vascular disease. And so, the key points with this disease is that everyone with STAT1 gain of function develops CMC, but then there's this other population, depending on where the mutation in the gene is, usually in the DNA binding domain, that develops more severe disease. So there's current thinking that some of these individuals can be monitored with conservative therapies, others really need to go to transplant. So only a couple more tables. You're hanging in with me. I appreciate you all. These are the autoinflammatory disorders. So these are the diseases that sometimes have been called periodic fever syndromes or recurrent fever syndromes. There's now a wide variety defined at the molecular level. I'm not going to actually present a case of this, but I'll say that many of you have probably already met a patient with periodic fever syndrome. These are individuals who often go for years just chalked up to having routine viral infections, common fevers, until 2-3 years down the line, the families really actually come in with the diagnosis and they say, I can set my watch by the time my son or daughter is going to spike their fever again. It's every 4 weeks, it's every 5 weeks, it's every 6 weeks. And, we've had the throat cultures, we've had exams, everything's always normal, but they get these terrible fevers. So sometimes it's a rheumatologic condition, systemic JRA and other conditions, so we do need multidisciplinary input. Sometimes it's a malignancy. But these children will usually be really sick and look miserable when they have the fever, and then in between febrile episodes, oftentimes they look like every other healthy child and are not showing a picture of a systemic disease. They can have joint symptoms, they can have cold-induced urticaria, and they can have systemic disease of liver and kidney. The periodic fevers without the stomatitis, pharyngitis, and adenitis, or PFAP, is the most common. I have a couple of those patients I care for here. I share with you as well. And these patients actually do really well. They kind of end up, losing this phenotype over time. Sometimes they have their tonsils taken out, and that seems to cure the disease for unknown reasons. Sometimes they just need colchicine or, other medicines that are quite safe for a period of time. Relevant labs in these patients mostly rule out other disease, include inflammatory markers, CBC, CMP, and an infection workup. Some of these individuals do very well with anti-IL-1 therapy, in particular those individuals with cold-induced urticaria, very safe medication that ends up, providing very good quality of life. And then the last set of disorders that I'll just mention today are the complement disorders. So whereas the antibody deficiencies are the greatest proportion of the pie chart of PI, the complement disorders are the smallest, representing about 1% of the known disorders of human immunity. And these span everything from recurrent infection to recurrent inflammatory disease, or a combination of serious bacterial infections and autoimmunity to susceptibility to neiserial infections, and even the hereditary angioedema, which falls into this category, a rare tyrosine kinase deficiency that causes recurrent swelling. So this was a 6-year-old boy that had bacterial infections, arthritis, and rash. Again, a theme of recurrent serious bacterial infections. He had over 11 admissions for bacterial pneumonias. This was somebody who truly had bacterial pneumonia, was very compromised. He had chronic rhinosinusitis. One of his pneumonias landed him in the ICU. It was a complex empyema that required chest tube placement, and he was mechanically ventilated. He also had this unusual recurrent purpuric rash, and he had large joint swelling, so he had a lot of kind of inflammatory red-hot knee, red-hot elbow, had some hip pain from time to time. So he had this kind of mixed picture of autoimmunity and infection due to serious bacterial infections. Interestingly, when we evaluated him, I'm talking about complement disorders, but he had a low IgG, which is not typical for complement disease. So that was a little bit of a head scratcher. He also didn't respond to his pneumococcal vaccines, but he had a normal CBC. The CH50, the total hemolytic complement screen that I like to send out of the gate just to make sure that at least the classical complement arm is normal, was strikingly abnormal. So in this patient, we ended up measuring each individual complement protein, and he had no C3 demonstrable. His rash was biopsied, and this was consistent with vasculitis. So he had this, again, unusual mixed picture. Genetic testing was done. C3 gene was sequenced just to confirm that he indeed does have a C3 deficiency, which he did. He had homozygous variants, so pretty atypical. So both parents carried the same allele and same variant. Distributed that to him. So he was diagnosed with C3 deficiency and humoral immune deficiency, so IgG deficiency. I can tell you that over time that resolved, whereas, of course, his complement disease didn't. He was given IVIG, did quite well, and just followed and co-managed by immunology and rheumatology. So, C3 deficiency is very, very rare, and this is the pathway that, of course, as medical students we're all tortured with, and asked to regurgitate on a variety of exams. I can see people sweating in the back of the room, but essentially, the early complement deficiency, the C1, C2, C3, and C4-ish, will often present with infections and autoimmune disease, whereas the latter cascade defects, C5 through 9, or the membrane attack complex, these are the individuals that have problems with severe neiserial infections, fulminant purpurins, meningococcemia, and so forth. So again, C3 deficiency, very rare. Bacterial infections, lupus-like phenotype, or vasculitis in the case of this patient are common. There's a high risk of nephritis, so co-management by nephrology is critical. And again, very, very few of these individuals are known. So I'll just spend just a couple more minutes, and then I definitely want to leave time for questions. Genetic testing, of course, as you've heard, as a consistent theme throughout this talk, has really become a mainstay in making the diagnosis of these patients with PI. We now estimate that about 40% of the time, at best, we can get a genetic diagnosis for someone who presents with a strong immunological phenotype. So for a variety of reasons, we're still searching for that other 60%. So there are many patients that are clinically defined at the clinical level with PI, but don't have a genetic diagnosis, only about 40% of the time. We used to, as in the case of the XLA patient that I mentioned, just do single gene sequencing and say, this phenotype is so striking, I know a lot about the genetics of these disorders, I'm just going to sequence this one gene. It's either going to be a home run or a strikeout, right? But we're moving away from that because, again, these patients present in a wide variety of ways. So sometimes microarrays can be helpful. You see copy number abnormalities, deletions of the genome, or additions to the genome as causative for some of these disorders. But more and more targeted panels, like say a gene panel that encompasses 500, 550 genes that are known to cause these disorders, is sent. They're pretty cost effective. Some problems around that. Some of the coverage isn't ideal. Some of the read depth isn't ideal. So more and more and more, as the cost of whole exome sequencing is coming down, I'm starting to send whole exome sequencing out of the gate on these patients, and then whole genome will, of course, is available, but it's still quite expensive. So, some of the considerations around this are, what's the clinical phenotype of the patient? Is it most cost effective to just send a panel? Often it is, or do we go straight to Wes because there are, 20 genes out there? We want greater read coverage, et cetera. The bioinformatics piece is really essential. So there's a few labs that I will work with because I know that they do a great job with disorders of immunity, and we're more likely to find these patients than not. But really, many of these diseases are diagnosed, and ultimately the patients are optimally cared for with a good history physical exam, some really basic labs. So, certainly I presented patients that had striking clinical histories, but we all know in this room that many of these patients, present with, this seems not quite right, but I'm not terribly worried about you yet. As pediatricians, we get so good, and I did med peds, so as pediatrician, you can just kind of look at someone and say, I'm worried about you, even though your chart doesn't look scary, or your chart looks really scary, but you look pretty good. And we're good at that as pediatricians. So the history and physical exam still is so important. And then just basic CBC with differential, making sure the differential is normal. That'll help you with any kind of T cell or often lymphocyte combined immune deficiency, B cell disorder. Comprehensive metabolic profile urinalysis, again, to look for secondary causes of antibody loss, renal disease. Antibodies, of course, IgG, A, M, and E, and then titers to vaccine and a CH50. That's a great initial evaluation for immune disorders. And you're going to catch the vast majority of individuals with that. We can go on to additional expensive testing, but more and more and more, and I'm reviewing some papers currently that are suggesting that we should go to genetic testing right after having a high clinical index of suspicion and doing basic labs that confirms that suspicion. So rather than spending $20,000 on flow cytometry, let's do whole exome sequencing. I'm still a big fan of functional validation of a genetic variant because you want to make sure that especially a variant of uncertain significance is causing the disease. But most of these disorders, it's history and physical exam, a basic evaluation, and then conditions like chronic granulomatous disease, the DHR, can be so helpful. So I'll just remind you of our PEPI program, and thank for those of you that collaborate with me to care for patients. I think the key takeaways is we can think about these patients across the spectrum by the types of infections, inflammatory disease, and immune dysregulation they present with that can help us with our genetic evaluation. Remember again that many of these patients will have unusual patterns of inflammation or immune dysregulation and not infections and still have an underlying PI. Again, early genetic testing and having your geneticist's phone number on speed dial is critical. We are very focused on the natural history of these disorders and doing personalized medicine, and so there are a number of druggable targets that can really improve outcomes for patients, such as JAK inhibitors in the patients who have JAK-STAT pathway defects. And then again, probably the other theme you heard is genetic testing, but also transplantation is curable in many of these individuals. So either being at a transplant center or again, phoning a friend at a transplant center to collaborate with these individuals, with these teams to care for these patients. So I have some CME questions that I can put out there. We have 5 minutes. Who wants questions if you just wants to have a Q&A? Questions, yes.
What sort of anticipatory guidance do you give the families in regards to genetic testing and then later obtaining health insurance?
Yes, okay, great question about anticipatory guidance via genetic testing and then subsequent insurance. So, I will say that, for these, of course we have, DINA and other, legislation out there that doesn't necessarily protect everyone, although it should. Most of the time, to be honest, for these individuals, the child or the adult is so sick that understanding whether this is a transplantable disease or not, they've already had lots of medical care and they've had chronic, problems. So, we fight with them, but having the diagnosis is still, I think, critically important, and the risk-benefit favors benefit. We do talk about that, though, and of course, our notes reflect the fact that this is a chronic disease and the patient needs ongoing, chronic multidisciplinary care. And it's still a small cohort, even though I've taken care of hundreds of these patients. I haven't run into that issue yet where they've been denied care or discriminated against, but we're vigilant around it.
Do you ever encourage them to get life insurance before the testing?
I haven't. That's a great point.
They don't have the same laws as the health insurance.
Yeah, that's a great point. I had the point was, do I encourage them to get life insurance before genetic testing? So I haven't made that part of the practice, which is a great suggestion.
I wouldn't, for immunodeficiencies, I don't think that's as important as maybe like a neurological problem. But it depends on the age of the patient and sort of what we're predicting, how serious their disease is going to be. I mean, patients could be uninsurable because of frequent infections and don't necessarily have to have a genetic diagnosis added to the chart to become uninsurable.
Great point. Thanks for that. Yes?
With the 10 warning signs table that the Model Foundation has had out, I have a lot of difficulty with the first two.
Yes. The ear infections,
How many
sinus infections.
How many days in a week does a pediatrician see a kid with recurrent ear infections? And we have to take into account the accuracy or type of diagnosis of each of those. And I think ear infections, sinus infections are very low threshold to go to a acute care center and say, oh, you have an ear infection, and not really reading out, we don't know viral, bacterial, severe, not severe, or OM, chronic infusion. So I find those 2 points difficult to deal with. And I don't want to send everybody with those to you to try and sort it out. So
yeah, it's a great point, and that is around the frequency of ear infections or sinus infections. And I think the 10 warning signs are really a rule of thumb. They are not they're not a diagnostic tool, but they're just an aid. So I think if you're worried about someone, my doors are open, regardless of whether they've had, met threshold for, kind of GMF warning sign 1 or not. Whereas if you're not worried, I mean, of course, I'm always happy to talk with anyone, about these cases. But I would agree that not all of the warning signs are created equal or weighted sufficiently to really warrant, concern. Yes.
So along the same lines, so we have that kid, we're kind of right on the middle, right? And we kind of do that initial tier evaluation. That being normal, would you recommend those kids stay with us, or barring us being super worried about them? Because I think of like 4 AOMs, right? That's also the referral criteria to go to ENT, right? For tubes. And so those kids we send to ENT a lot, in which again they may be benefited with tubes with the fusions, not just the otitis piece. And so the diagnostic accuracy of a true AOM is maybe not quite as important there. But say we've made those 4 diagnoses, do you want, if any kid were doing lab eval, do you want them to still go to you to get the final blessing? Or like what would be an appropriate threshold there?
I mean, I think if they have acute otitis media 4 or more times and, the antibody levels are normal and there's not anything else going on, like they haven't been hospitalized with pneumonia or something like that, which is what we're definitely talking about. I mean, of course, my door's open, but I'm sensitive to, the burden on the patient and having another, specialist weigh in and so forth. So I really appreciate the question. So kind of within that context, I would say their antibody levels are normal. They haven't had any other issues like GI issues or failure to thrive. It's just ear infections. Yeah, I mean, I think the ENT is going to do much more for that patient than I am, and I think that's absolutely appropriate. Whereas if you're worried at all, something else happens, you're like, they're kind of falling off the growth curve. Yeah, of course, doors wide open. So, yes.
Have we learned anything about the genetics or the immunology of people who have either severe COVID, MIS-C, or long COVID, right? Because it's new.
It is new. It's a great question about the genetics of, this novel pathogen as of 2020, COVID. and whether that uncovered any defects in immunity. So the answer is yes. I mean, MIS-C and long COVID are still mysteries by and large, to my knowledge. But there was a form of X-linked TLR, toll-like receptor deficiency, TLR4 in particular, that caused early death in men with COVID. So there was a cohort that was published, and I want to say 21 or 22, of men that died very, very rapidly of COVID. And they were otherwise healthy, and they were often young men, 20s, 30s. And so they were found to have these TLR mutations. And so that was an example of uncovering a novel genetic disease with a novel pathogen. It's a really great question. And I think we're probably going to still learn, a lot, just because so much to be learned. It's a great question.
I was just going to comment on AI and informatics. I had a patient come in recently. She downloaded her MyChart and she categorized all the child's illnesses over time, symptoms, weight, and she brought it in. And I think this child has an immunodeficiency. And I think mom pretty much, in a good way, she did a really comprehensive review and used technology to help. I think I sent her to you to help.
Did they come already? Or? Okay,
Yeah.
Thank you. Thanks for the heads up. Yeah, that's fantastic. That's fantastic. And for, often the parents do come with a diagnosis, right? And so that's incredible. Yeah.
And that's probably one of the most difficult tasks for us clinicians is putting together the breadth of information that would be taken at different locations, different systems, EMRs disconnect to try and figure out what are the recurrent episodes for this child really having. And parents forget even sometimes significant events and others don't. And having AI integrated EMR probably be a big help in tracking that.
Absolutely. And even more portability. I mean, we kind of talk about portability of health records, but it's not really portable. I mean, two centers have Epic. Yeah, thankfully, we can see care everywhere. But if you got like Epic and Cerner and you're 10 miles apart, then the patient's coming in with either a stack of papers, sadly, or a very, very, very large set of PDFs. And, that's not what we want. So it's not helpful for the longitudinal record, Yeah, but hopefully we'll be able to solve some of those issues with systematic improvement. Thank you all one last question, yes.
Will there be any difference in obtaining labs when they're ill versus when they're normal?
Terrific question about, illness-related labs versus the autoinflammatory disorders are a particular set of disorders where you really do want to get labs when they're sick because their inflammatory markers can be stone cold normal, SED rate, ESR, completely normal. Even cytokine profiles aren't that helpful, but even if you do that, it can be completely normal when they're well, but when they're sick, inflammatory markers are sky high, etc. So that's a particular set of disorders where you do want to pay attention to the chronicity of the illness. And I'll often, put in a set of future lab orders and just, again, provide anticipatory guidance to the family, like, please get these labs drawn, if your child's sick, because I'd really like to see what they look like. The other disorders, most of them it's chronic, so you're going to see like chronic lymphopenia. You're not going to see, unless there's a drug effect, like they're on steroids or something like that, you're not going to see much fluctuation. They're going to have low lymphocyte counts or low CD4 or CD8, etc. But yeah, really terrific question. Great. Thank you all so much. Really appreciate it.